Good morning, friends. What happened? Today, our guest speaker is Dr. Sameer Malinkari from Pune. He will be lecturing on MDS Pitfalls for the Clinician. This webinar is brought to you by Mumbai Hematology Group. It is supported by NATCO and managed by Perfect Square. I thank Mr. James Raja Kumar and the team from NATCO, Mr. Yash, Mr. Kalpesh and team from Perfect Square, the Executive Committee of Mumbai Hematology Group. Our chief guest today, Dr. Anand Casey from Bangalore. Our chief guest speaker today, Dr. Sameer Malinkari from Pune. All our discussants were themselves eminent hematologists or hemato-oncologists. You participants for sparing your Sunday morning, afternoon, evening. Next Saturday, that is 5th August, from 7 p.m., we have Dr. Abdul Rahim Yaqub from Kansas Health System, who will be speaking to us on management of myelofibrosis in 2023. Just prior to this scientific talk, we are going to have a talk from 6:15 onwards, about which I will email you. So the webinar will begin at 6:15 and not 7 p.m. on coming Saturday. Sunday, 6th of August, 11:30 a.m. IST, we have Pranta Chakrabarti speaking to us on thrombophilia, when and how to investigate and treat. And now it's time to look at our discussants. And we've got a good number of them from various parts of the country. And they are alphabetically put up here. I'll very briefly introduce them to you. Dr. Aditi Shah from Mumbai. Dr. Aditya Jandial from New Chandigarh. Dr. Akshaya Mandloi from Varanasi. Dr. Alka Kadwal from Chandigarh. Dr. Amit Khurana from Surat. Dr. Anant Gokarn from Mumbai. Dr. Arihant Jain from Chandigarh. Dr. Ashutosh Panigrahi from Bhubaneswar. Dr. Hamza Dalal from Mumbai. Dr. Kunal Goyal from Varanasi. Dr. Nakul Tikare from Bhubaneswar. Dr. Niranjan Khare from Chandigarh. Dr. Prathamesh Kulkarni from Mumbai. Dr. Pritish Chandra Patra from Bhubaneswar. Dr. Priyanka Samal from Bhubaneswar. Dr. Shilpa Gupta from Mumbai. Dr. Shweta Bansal from Mumbai. Dr. Siddharth Sankar Ray from Kolkata. Dr. Sisir Patra from Kolkata. Dr. Sumit Mirg from Mumbai. Dr. Thomas Kuncheria from Bhubaneswar. Dr. Urmimala Bhattacharji from Chandigarh. And Dr. Vivek Agarwala from Kolkata. A few words about our guest speaker of the day. He doesn't require any introduction. He's made a huge name for himself. He's head Department of Hematology, Director Blood and Marrow Transplantation at the prestigious Deenanath Mangeshkar Hospital, Pune. He did his DM in clinical hematology from CMC Vellore in 2007. Earlier, he did his MD medicine from BJ Medical College, Pune. His major interest is hematopoietic stem cell transplant, and he has a number of publications and research experience as principal investigator in related fields. He will be speaking, as I mentioned, on MDS Pitfalls for the Clinician. Before he does that, it's my privilege to introduce the chief guest of the day, and that is Dr. Anand Casey. Once again, he's well known to all the people who are listening to me today. He's consultant and head Department of Pediatric Hematology, Oncology, and Bone Marrow Transplantation at Shankara Cancer Hospital Research Center, Bangalore. He pursued super specialization in pediatric oncology from TMH Mumbai. He has several publications in peer-reviewed journals and oral presentations to his credit at various national and international conferences. His work in clinical research is recognized by Young Icon Award by Indian Cooperative Oncology Network, that is ICON, in 2015. He's also an active member of the various professional organizations, including PHO, IAP, and CIOM. His academic interests include pediatric bone tumors and pediatric lymphoma leukemia. I request Dr. Anand Casey to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Anand.
Good morning, everyone. I'm one of the youngest of junior faculty who is attending this MSG. 10 years back, I was attending the physical quarterly meeting with under Dr. Mamta Manglani as my mentor at the same Mumbai. And 10 years down the line now, I've been invited as a faculty. It's like a dream come true for me at this point of time. Sir, MBA Agarwal sir must be remembering that yearly book previously he was launching a hematology book. I used to take his autograph in one of the books, and that's how the hematology interest started in 2011-12. And later, after finishing my MD course, I joined Tata Hospital as a senior resident in pediatric oncology, and later joined as a DM trainee. And once I finished, I moved to Bangalore, and currently I'm working at Shankara Cancer Hospital and Research Center, Bangalore. So the mentors like M.B. Agarwal sir and Mamta Manglani ma'am, and again Dr. Banavali sir and Girish Chinnaswamy sir and Brijesh Arora sir at Tata Hospital, these are the ones who inspired me to join the hematology, and now working at Bangalore. So when I joined Bangalore, it was just a 4-bedded unit which I started 5 years back. And within a span of 5 years, now we are a 40-bedded unit with 4 faculty, and we have started bone marrow transplantation unit, and we have a FNB course, and I am one of the youngest teachers for issuing or being a teacher of the FNB students. So I would sincerely thank the M.B. Agarwal sir for providing me the opportunity to come and join me at the MHG seminar or CME today. So I would like to say 2 things or 3 things for juniors. One thing is in hematology, it's one of the very exciting and interesting branches, and a lot of research in terms of translational, clinical, and in the laboratory level, it's happening in the molecular as well as targeted therapies. So it is one of the very exciting branches. So I would request all our juniors to consider hematology as one of the interesting topics to pursue super specialization with. Second, to have a mentorship with teachers like M.B. Agarwal sir and your teachers at your institute is very, very important for not only completing your course, but afterwards in guiding your clinical management as well as leading in the professional career. After that, choosing a wisely choosing a decision to join a center which will give a balanced perspective of your professional life as well as clinical, academic, and research is very important. And finding a good team and overall with a good clinical acumen to serve the patients. That's all I think it's needed to excel in hematology. And I strongly feel anyone who is interested and who is motivated in hematology, I think it's one of the very good branches in medical field to have a good career. That's all I would like to say. Thank you.
Thank you so much, Dr. Anand, for those kind words and the message for the colleagues as well as the students. Extremely grateful to you for sparing your time and giving this wonderful talk to inaugurate this webinar. Moving on to now Dr. Samir Malinkari. Official introduction has been done, but I must tell you that he's a gem of a person. I've had very close relationship with him because Pune and Mumbai are like twin cities. So there have been a lot of interactions, scientific and social. There have been a lot of occasions of visiting Pune, and Samir has never refused to come to Mumbai whenever there is any opportunity in the academics. Road journey, 2-3 hours, one way, again going back, and the hardship of entering Mumbai and hardship of entering Pune, traveling those cities. This man has done all that at number of occasions, sometimes 2 or 3 times in a month. And that speaks volumes about his love for teaching and academics. Single-handed, he has developed the Department of Hematology at Dinanath Mangeshikar. I had the privilege of being invited to see the department He took me around personally and showed everything. And what a beautiful department he has developed. Today, it is one of the centers that everybody looks upon, both for learning, for doing post-graduation, for doing research, and the patient care. I must say, and Samir will witness, that we send patients even from Mumbai to him for the care as well as transplants. Mumbai is an expensive place, and Samir handles them at virtually half the price of what we can do in Mumbai. And that is a great asset to 50% of the Mumbaikars who cannot afford Mumbai as the center for treatment. Not only that, it's also the quality of care and the results that he produces. And that is what gives us confidence to keep referring patients other way. And it's very unusual that a South Mumbai patient will go to Vasai and take treatment. When you say a patient goes from Mumbai to Pune to take treatment, it may be surprising to somebody, but that's the reality of life. And the credit goes to Samir for achieving that. I think with that, Samir, go ahead.
Yes, sir. So at the outset, I'd like to thank Dr. N.B. Agarwal and the Mumbai Hematology Group for bestowing this honor upon me. And I must say that I'm truly privileged and thrilled to be here today. So I am going to discuss myelodysplastic syndromes with particular emphasis on some of the newer concepts and terminologies. And along the way, I would illustrate certain situations where the clinician may get confused when he is diagnosing and treating these patients. Just a second. Okay. So to begin, let's take a hypothetical case. So this is an older gentleman who has no previous medical ailments. He's come for a routine checkup and is noted to have the following parameters. He's got a normal hemoglobin. He's got normal platelets, but he's got mild leukopenia with a normal differential WBC count. So when this patient comes to you with this routine health checkup report, what would you do? So I would probably just wait and ask him to repeat the test after a few weeks, because this may just be a transient leukopenia, maybe secondary to some recent viral infection or so, and therefore I would ask him to just repeat the count. So this man goes back and comes back about a year later, and he's done multiple CBCs over this 1 year, and consistently it shows the same pattern, that the WBC count is always below 4,000. Now I feel that this warrants further evaluation, and that would warrant a bone marrow biopsy. So I go ahead with a bone marrow biopsy, and that shows that the marrow is essentially normal. But I'm not satisfied, so I also go ahead and do a karyotyping and a FISH for MDS panel on the marrow, and this also turns out to be normal. So now what would you do, right, for this patient? So would you reassure this patient and ask him to forget about the leukopenia and just say that it's nothing very significant, we've done the workup so far? Would you do any further tests? And finally, what would you label this patient, right? So maybe until a little over 5 years ago, we would have probably stopped at this stage because there were no further tests available, and we would just probably monitor this patient. But now you must know that a myeloid mutation panel by NGS, which is now routinely available, is a very important test in the diagnosis of unexplained cytopenia. So we go ahead with a NGS panel, and this patient turns out to have a DNMT3A mutation with a variant allele frequency of 10%. So now the question is, what would you call this patient? So, and what would you advise him? So we must first understand certain newer terminologies, relatively newer terminologies that exist today. And these include clonal hemopoiesis of indeterminate potential, idiopathic dysplasia of uncertain significance, idiopathic cytopenia of undetermined significance, clonal cytopenia of undetermined significance, and MDS, right? So what is a CHIP? So in a CHIP, you have no cytopenias. So if you have no cytopenias, why would the patient undergo an NGS test, right? So this may be sometimes done for, as a part of routine, a trial or a clinical study that has been done, or somebody has had a relative who's had an AML and therefore he wants to do a genetic screening, or maybe he's got a portal vein thrombosis and he wants to look at somebody's done a JAK2 mutation and it turns out to be positive in the absence of cytopenias, so calling it as JAK2 chip, and so on and so forth. So if you find such a mutation, generally it must be more than 2% to call it as significant, and it is generally at a very small VAF, right? And the most commonly seen mutations are DNMT3A, TET2, ASXL1, SRSF2, and TP53. And there's a very low risk of progression to AML in this patient. Then comes idiopathic dysplasia of uncertain significance, where the patient does not have cytopenia again, but he undergoes a bone marrow for some other reason, whatever it may be. Maybe he had a backache and he got an MRI done. The MRI showed some changes and somebody asked him to do a bone marrow. And when you do it, actually, you see that there is a small percentage of the bone marrow cells which show clear-cut dysplasia. This is called IDUS. Somatic mutations may appear subsequently and the risk of progression is truly not known. This is a sort of a rare situation where you discover this entity. Then comes idiopathic cytopenia of undetermined significance, where the patient would have one or more cell lineages that are cytopenic. There is no dysplasia. There are no somatic mutations. So essentially, you don't see any abnormality at all except the low blood count, right? But these patients, about 10% of them at 5 years are likely to progress to MDS AML. And why does this happen? Probably because your tests have not detected the mutation, or we still don't know what the mutation was. But so anybody who's got a cytopenia, a leukopenia of unknown origin, unknown cause, don't leave them alone. Just ask them to intermittently keep checking their CBCs and follow them up. And then comes CCUS, where there is cytopenia, there is no dysplasia, there are somatic mutations, one or more, and the risk of progression of these patients is about 80% at 5 years to MDS, right? So our patient who had the DNMT3A mutation with a VAF of 10% falls into the category of CCUS. So depending upon which mutation the patient has, the prognosis alters and the chance of developing MDS may be different. And then MDS, of course, you've got cytopenias, you've got more than 10% of the bone marrow cells showing dysplasia, and somatic mutations are seen in virtually all the patients. Okay, so introduction to MDS, it is a bone marrow failure syndrome. It is termed as myelodysplastic neoplasm now by the WHO. There is a production of structurally and functionally defective hematopoietic stem cells. And there is peripheral blood cytopenia involving one or more lineages. There is a propensity to develop acute myeloid leukemia. So how does one suspect MDS? Generally, because there is a presence of cytopenia, which may be symptomatic or asymptomatic, and this then prompts evaluation of the bone marrow aspirate and biopsy. And I'm going to show you some clear-cut pictures of dysplasia. Okay, so this is a normal neutrophil on the left. On the right, you have a pelgaeuriform classical dysplasia. This is a bone marrow, which shows these multilobated erythroid precursors, again, classical of dysplasia. You can see some internuclear bridging here and here, again, features of dysplasia. You have ringed sideroblasts. In the myeloid series, as you can see, really dysplastic multilobated myeloid precursors. And these are megakaryocytes. That's the normal megakaryocyte. And you have a hyperlobate and a micromegakaryocyte. Micromegs, again, are very classical hallmark features of dysplasia. Okay. Now, what I have shown you is black and white dysplasia. Why do I call it black and white? Well, because you cannot confuse the color of white with the color black, right? But then in medicine, everything is not black and white. There is the color gray. And when you have various shades of gray, you can sometimes be confused whether to walk in the direction of white or whether to walk in the direction of black. And there you can fall into a pitfall. So there are two important caveats that you must remember in MDS. The first is that in MDS, the bone marrow can have subtle morphological dysplasia and can be labeled as normal, right? Especially by the untrained eye. And the second is that what is labeled as dysplasia need not always be MDS. And I'm going to illustrate some cases later on for this effect. So before we move on, let's discuss the pathogenesis of MDS. So in the pathogenesis, there are three important changes that happen. The first are the genetic changes, which are present in almost all patients. Then there would be epigenetic changes, which are present in the majority of patients of MDS. And then in a minority of patients, you have autoimmune manifestations. Minority meaning it is estimated that almost about 30% of patients can have certain degree of autoimmunity going on in the patient of MDS. So there is always a neoplastic transformation of a clone. MDS is a clonal disorder. And the commonest mutations that you generally see are these, but these are not all the mutations. These are the commonest mutations that you see. So you have genes responsible for RNA splicing, such as SF3B1, which is the commonest, SRSF2, U2AF1. Then there are mutations in the DNA methylation genes, such as the TET2, DNMT3A, or the IDH1 and 2. Then in genes responsible for histone modification, such as ASXL1 and EZH2. And each of these has a different sort of prognosis about conversion into AML. So in SF3B1 would be more favorable, SRSF2 would be less favorable, ASXL1 would be less favorable, etc. And also, it is known that some of these mutations can coexist with others, right? For example, DNMT3A mutations would be more associated with IDH2 mutations, etc. So an NGS is important in all these patients. All right, now what do we have here? This is a cartoon showing, say, a snapshot of a part of your genome, right? And the one in the bracket is, say, the gene. So as you see here, you start moving on from here downwards, you see there are these cytosine preceding guanine islands, right? And as you start going down and down towards the gene, you see that these CPG islands start to increase. And when they start to increase, you know that you're approaching the promoter sequence of this gene. What does the promoter sequence do? It sort of controls the expression or repression of that gene. And how does it do this? Most commonly because of methylation that happens. So methylation of the promoter sequence typically happens on the CPG islands, right? And when you have a methylation of the gene, it is repressed. Whereas when it is either unmethylated or acetylated, then it tends to get activated. So we know that MDS or AML generally happens because a proto-oncogene is activated or a tumor suppressor gene is excessively methylated. And that's where your hypomethylating agents actually help in the treatment of the cytopenias of MDS. So this is what I just discussed, that the epigenetic changes. Epigenetic changes are now increasingly being recognized as pathogenic in MDS, and there are certain instances such as the promoter methylation of the beta-catenin gene is important, 5q- syndrome. Promoter methylation of this particular gene is noted in monosomy 7, and so on and so forth. Then coming to autoimmunity. So we know that aplastic anemia, MDS, and PNH can sort of coexist, and therefore MDS can convert into aplastic anemia. We know that aplastic anemia is an autoimmune disorder. Now there are surrogate indicators of the role of autoimmunity, and we see that various immunological, rheumatological manifestations occur frequently at presentation in these patients. So we've seen patients with severe inflammatory arthritis as the presenting manifestation. You know, a lady I knew who had severe inflammatory arthritis was treated for 1 year with mild cytopenia where the marrow was completely normal. And then 1 year later, she suddenly converted into AML. Okay. So response to immunosuppression, some of these patients sort of proves the role of autoimmunity as well. Now, this is a patient whom we recently had. This was a 16-year-old girl who had severe transfusion-dependent anemia, requiring about 2 transfusions per week. Her bone marrow was morphologically normal. She had normal retic count, DCT, and LDH. And we labeled her ultimately after ruling out various other causes of hemolysis, that she had a Coombs negative autoimmune hemolytic anemia. And this patient would just not respond to multiple immunosuppressants and lenalidomide, danazol, etc. Everything was thrown at her and she did not respond. And when we did her NGS, she turned out to have a significant EZH2 mutation, which where the germline was negative, it was a somatic mutation. So this patient was labeled as a CCUS or MDS with refractory immune hemolytic anemia. And this patient had to undergo transplant subsequently. So it is known that significant amount of autoimmunity exists, including T cell as well as B cell autoimmunity, which can happen in the inflammatory milieu that exists in MDS. Then come to cytogenetics in MDS. Cytogenetics forms an important basis of the classification and prognostication of MDS, and these can be done by either karyotyping or FISH or by MLPA, which stands for multiplex ligation dependent probe amplification, or chromosomal microarray. Now we know about karyotyping and fish, so I won't discuss that. But in fish, I must tell you that only 4 loci are covered. Okay, and there are so many other abnormalities that we know of in MDS, and so these are not covered in the fish. So the MLPA, this is a test that we've established in our hospital. It covers about 12 loci, and the resolution is better as compared to fish. However, you have to have a much higher mutation load to call it as for it to be picked up on the MLPA. So if you have a significant amount of dysplasia in the marrow, then it's more likely that your MLPA will pick up the mutation as compared to your fish. And coming to chromosomal microarray, this is another test that interests me a lot, and we have established this test as well in our hospital and are offering it as a routine test. So it basically is a test which covers the whole genome. It's like a whole genome screening. I don't have time to discuss this in detail, but it detects everything that a karyotyping and fish would detect or an MLPA would detect. And in addition to that, it will pick up something called as the copy neutral loss of heterozygosity, which gives you additional information about the mutation status of a gene. So you may not have a deleted gene, but there is a copy neutral loss of heterozygosity. So for example, if you see a CNLOH at the 17p locus, you would know that it would be indicative of a TP53 mutation. And then you would sequence it and actually find out what it was. Unfortunately, this is an upcoming test, and therefore it's not yet been incorporated in the WHO risk classification. So there are some cytogenetic changes that do not require morphological dysplasia. The pathologist told you that I'm not very sure about the dysplasia in the marrow, but you've done a karyotyping and you've seen 5q minus, deletion 5, monosomy 7, 7q minus, 17p minus, complex karyotypes, or chromosome 3 abnormalities. These are hallmarks of MDS in the presence of cytopenia. And now the WHO has classified these genetic risk factors into various types, which could be, which could be either good prognostic or very good prognosis, or good or intermediate or poor or very poor. Okay, and it's difficult to remember all of these, so you can always refer to this chart whenever you see a patient of this condition. Okay, now coming to classification of MDS. We used to have an age-old classification, the FAB classification, which existed for many years when I was a student. But now this has been replaced by the WHO classification. Right? So in the WHO classification, we'll just go through this. You have MDS with defining genetic abnormalities and MDS which is morphologically defined. In the genetic abnormalities, you have the 5q minus syndrome, where there are low blasts, and you see on the karyotyping that you will see 5q minus. Then you have the MDS with the low blast with SF3B1 mutation. And this must have the absence of 5q deletion, monosomy 7, or a complex karyotype. And on mutation analysis, you see SF3B1 mutation. Now, there's a caveat that if you see more than 15% ring sideroblasts, then that can substitute the SF3B1 mutation. It's also an accepted terminology. You have MDS with biallelic TP53 inactivation, where the blasts are less than 20%. Cytogenetics tend to be complex most times. And if you do a mutation analysis, you see 2 or more TP53 mutations with evidence of, possibly with evidence of copy number loss of heterozygosity or seen on a microarray. Then you have MDS, which is morphologically defined. In that, you have MDS with low blasts. You have MDS hypoplastic. You have MDS with increased blasts. It's called IB1 or IB2, depending upon the number of blasts that you see. And then finally, you have MDS with fibrosis, which was a long-awaited inclusion in the WHO classification. Once you have diagnosed MDS, you need to prognosticate it, right? And the IPSSR scoring system exists. And I can assure you that this is not the last IPSSR that you would be seeing. You're going to keep seeing more and more IPSSRs. So the current one depends upon cytogenetics, whether it's very good, good, intermediate, poor, the blast percentage, the hemoglobin value, the platelet count, and the ANC. And you don't have to remember this, you don't have to mug this. If you have an MDCalc app, you can easily put the values onto that and you'll get your IPSSR, right? And then this is now classified into very low, low, intermediate, high, and very high. And I do hope that in future IPSSR, we don't have very high, very, very high, and very, very, very high. You know, it'll go on and on. So this is already quite confusing. Earlier, we used to have a much simpler classification, but now this is getting more and more complicated. Okay, now coming to MDS differential diagnosis. Okay, so I'm giving you an example of, of this, say a male who has a severe anemia, mild to moderate leukopenia and thrombocytopenia, a normal retic count, macrocytosis, PBS shows oval macrocytosis, hypersegmented neutrophils, the LDH is high, and the diagnosis is megaloblastic anemia. If you do happen to do a marrow for this patient, you would see that the morphological appearance of the nucleus of the erythroids and myeloid precursors is characteristic in megaloblastic anemia. But let me tell you that such changes are also seen, the similar changes are also seen in MDS. And here we call it as megaloblastoid morphology of the nucleus. So these are very difficult to sometimes differentiate, and they can be quite similar, all right? Now, if you have the same patient with the same parameters, but the patient has had symptomatic anemia requiring multiple blood transfusions and has received vitamin supplements over the last 6 months, and he comes to you with the same parameters and there's an LDH which is normal, you're not going to suspect megaloblastic anemia. And this is a patient where you would suspect MDS. And I'm going to come now to 3 particular cases which I'm going to discuss. These are real cases which I have encountered in my practice over the years. So the first case was a 25-year-old man who was working on a toll booth. He presented with high-grade fever and was admitted to a peripheral hospital with sepsis, possibly bacterial, a viral with superadded bacterial infection. He had no significant past history, was a chronic gutka chewer with no blood transfusions in the past. He had no significant clinical findings, and these were his blood counts, right? Severe pancytopenia, right? With a slightly high MCV. He had septic hyperbilirubinemia and mildly raised transaminases. The LDH was raised, but this could also have been because of the deranged LFTs, right? So this patient then underwent a bone marrow biopsy, and this was reported as being severely dysplastic. So this patient received RBCs, he received platelets, he received some vitamin supplementations, antibiotics, and after about 1 week of admission, there was no improvement in his blood counts. So then I explained the guarded prognosis, saying that, this could be dangerous and we don't know, we'll have to, observe you, cover the initial, treat you with good antibiotics, and subsequently you may have to go in for further workup and, etc. And then he took a second opinion from another hematologist who advised him that, with the presence of such severe, cytopenia, it is best to, quickly go in for an urgent bone marrow transplant, give a reduced intensity conditioning, and quickly get normal cells on board after the transplant, so that's the best way to counter, further infection. So this patient was quite poor, and therefore he couldn't undergo that transplant anyways. So we decided to continue with antibiotics and vitamin supplementations. These which have continued, and he then recovered from the infection, got discharged. And 4 weeks later, this patient came with a hemoglobin of 14 grams, WBC count of 8,000, platelet count of 3.5 lakhs, right? So what was this patient? This patient had megaloblastic anemia in a patient with sepsis. So it must be remembered that sepsis can cause severe dysplastic changes. You don't diagnose MDS in the presence of sepsis. And sepsis, we know, can suppress the bone marrow and delay recovery from the cytopenia of the megaloblastic anemia. So it may take a much longer period. And the best way to differentiate between, when you're confused between megaloblastic anemia and MDS, is to give a therapeutic trial, a sufficient therapeutic trial of B12. Otherwise, you're going to end up transplanting patients with megaloblastic anemia, right? So macrocytic anemia is seen in megaloblastic anemia, MDS and aplastic anemia, hypothyroidism, and liver disease. So don't forget all of these conditions. There are drugs which can cause dysplasia. So cytotoxic drugs, hydroxyurea can cause a lot of dysplastic changes. Heavy metals, antibiotics, all of these can cause dysplasia. You must be remembering these. Then this is a second patient. Okay, this is a 55-year-old lady, came with fatigue, was found to have pancytopenia of this nature. She had no clinical findings, no lymphadenopathy, organomegaly. LFT showed mild hypoalbuminemia. RFT viral serology was normal, chest X-ray was normal, and the ultrasound showed no lymphadenopathy, and it showed a borderline splenomegaly, but there was no clinically palpable spleen. Bone marrow was done for this patient, which was reported as cellularity was normal. Erythroid hyperplasia with mild megaloblastoid changes. Iron stores were decreased. There were no ring sideroblasts. There was normal myeloid maturation, but there was mild dysplasia. There were adequate megakaryocytes. And the final impression given by reasonably good pathologists is that this is a normal cellular marrow with features of myelodysplasia. Consider MDS. So she saw a hematologist who advised fish karyotyping, which were normal. The hematologist started this patient on lenalidomide. She had rash to it, and then she came to me. And I sort of, thought like, okay, let's something has been started, might as well change to, to thalidomide and continue the same line of treatment. So I replaced the iron because it was deficient in the marrow, added erythropoietin, and then the hemoglobin actually improved. The patient was comfortable, followed up with me for the next 6 months or so. And one fine day, she developed massive hematemesis. And then an upper GI scopy was done. And what did that show? It showed grade 4 esophageal varices. So this patient had portal hypertension with hypersplenism. What you must remember is that sometimes ultrasounds can be deceptive, especially if not done by trained sonologists. Spleens need not always be palpable in hypersplenisms. And the best way to rule out hypersplenism is to do an upper GI scopy and confirm whether the presence of features of portal hypertension there. So this is again a very confusing patient, and you must not forget this entity when you're trying to diagnose undiagnosed cytopenias. And the last patient is a 50-year-old man who presented with transfusion-dependent pancytopenia, was seen by a prominent hematologist, and the bone marrow was done, which showed trilineage dysplasia. Fish karyotyping were normal, diagnosed as MDS, and started on decitabine. With this, he had severe cytopenia. He had bacterial and fungal infections, had a poor quality of life for a few months. There was no response seen after 3 months. Then he was treated. He became better. Saw another hematologist who switched to lenalidomide. There was no response to lenalidomide. And then HLA typing was done, and he was planned for a haploidentical transplant. Well, he saw me just before that for a third opinion. And not that I'm a prophet and I didn't know what he's going to respond to, but I just said, while you're waiting for the HLA typing, why don't you just take some steroids and see what happens? So I started giving him a trial of prednisolone. The patient started to show some response, and therefore I then quickly tapered down the steroid. And for an 80-kilo person, I just tapered it down to 5 milligrams because he was responding. And 6 months later, this patient had a hemoglobin of 17 grams, WBC count of 10,000, and platelet counts again, which were high normal. Okay. So in fact, we had to actually do a phlebotomy on this patient a couple of times to get his hemoglobin down. So this patient had possibly autoimmune cytopenia because it responded very well to steroids. But you must remember that when you're diagnosing autoimmune cytopenia, you must not forget to do an NGS for unexplained cytopenia. So this patient went on, he was doing well for almost 7 years. He had absolutely normal blood counts. He then stopped his steroids on his own. And couple of years later, this was during COVID period when he came to me again with cytopenia. Now I asked him to get a repeat bone marrow and NGS typing, and to confirm whether he truly has MDS now. But unfortunately, while this was happening, he developed COVID and he died of COVID. So we never got to know whether he was actually a CCUS and an MDS with autoimmune cytopenia, or whether he was a true autoimmune cytopenia and would have responded to a re-challenge with immunosuppressants. So the DDs of MDS, as I have discussed with you, would be megaloblastic anemia, infections, drugs, hypersplenism, and autoimmune cytopenia. All right, then we come to the treatment of MDS. So the challenges in MDS are that most patients are elderly. It's a heterogeneous disease. There is no clear standard of care. And the mainstay of treatment is improving overall survival. So the management of RBC transfusion dependence, you use erythropoietin or darbepoietin. The maximum dose of erythropoietin is 40,000 units twice a week, generally for an adult male. The time to response is about 8 weeks. So you shouldn't be impatient. It takes minimum 8 weeks to respond. And the chances of response, you have response in about 50% of patients. Those patients who have an erythropoietin level of more than 500 are unlikely to respond. And the best chances of response are if the erythropoietin levels are below 200. When you start erythropoietin, the median duration of response is about 18 months, after which the patient is likely to lose response to EPO and become transfusion dependent. Darbepoietin and erythropoietin are roughly equally good. To manage the neutropenia, one can add filgrastim at small doses, and it's been seen that adding filgrastim can actually help in the erythroid responses as well for certain unknown reasons, especially in patients who are SF3B1 mutated. To manage the thrombocytopenia, well, one should transfuse minimally unless the patient is bleeding, and the TPO agonists, when used at full doses, 150 milligrams of eldromopag or 20 mics per kg of romiplostin, they may, although they're not licensed, they can be used safely, and you may have some response to these TPO agonists. Then to manipulate the microenvironment, we know that pro-angiogenic cytokines are in excess, such as TNF and other inflammatory cytokines in MDS, and these cause apoptosis. So lenalidomide and thalidomide are said to work. In one study, about 27% of patients showed response to these drugs. These should be used, mind you, only in the low-grade MDS. You don't try len and thalidomide in patients with high-grade MDS. And most of the responses would last for about 1 to 2 years, after which many patients again would would have disease progression. The best responses, as we know, are seen in patients who have the 5q minus syndrome. We've seen that the combination of lenalidomide and danazol may benefit some patients, and you can have really durable, long-lasting responses in patients lasting for several years. Immunosuppressive therapy is typically used in patients who have myelodysplastic MDS with the presence of a PNH clone. In these situations, we would use ATG, but one must remember that if you have a mutation, the immunosuppressive therapy is only going to sort of treat the autoimmune part of it, but it will not change the genetic changes that have happened in the MDS, and therefore these patients in subsequent years can progress to AML, and therefore only because they've recovered from their autoimmune cytopenia, one would not sit quietly. They must be monitored diligently over the next several years. Up to 10, 15 years later, they can evolve into AML. What is luspatercept? This is a new drug, as we all know. It's been launched recently in India. And to cut a long story short, what it does is that those erythroid precursors, which are destined to not mature properly because of various reasons, because they're slightly defective, or there's an inflammatory milieu, and therefore there is repression of maturation of these neocytes. These are sort of pushed into maturation by this drug, right? So you have a war, and in this war, you have exhausted all your soldiers. And then you can take normal, civilians, and you start just pushing them into war. So it's something like that, right? You're increasing the RBC numbers, and you're trying to maintain a normal hemoglobin. Again, this drug is not going to improve your conversion into AML, but it is going to improve the transfusion dependence in a significant number of patients. The drug is expensive, but the best responses are seen in those patients who are SF3B1 mutated. But you can also use it in other patients with low-risk MDS. What about the hypomethylating agents? So we have azacitidine and decitabine, both can be used. These are DNA methyltransferase inhibitors and cause hypomethylation of the promoter sequences of various tumor suppressor genes, and that's how they work. They work in all classes of MDS, low grade and high grade. They improve the overall survival. They improve the transfusion dependence because they would sort of decrease the clone of MDS, and thereby allow normal cells to sort of proliferate. They would delay conversion to AML, but they do not prevent the conversion to AML. So how would you then treat a patient who has low risk MDS, okay, low IPSSR? So you would give supportive care, including transfusion support and ion chelation. Thrombocytopenia, you would attempt to give TPO agonists. If this fails, you might use an HMA and then go in for transplant if necessary. Patients who have, let's say, go to the non-deletion 5q. So whether it's deletion 5q or non-deletion 5q, you check the erythropoietin levels. If the erythropoietin levels in 5q minus are less than 500, you will still first treat with erythropoietin plus or minus GCSF. And only if this fails, then you would just check for the TP53 mutation and use lenalidomide then. Most patients respond very well to lenalidomide, but ultimately many of them fail and they progress. And if it fails, then you would proceed to an HMA without or plus or minus of allo-BMP. And the same thing with the non-deletion 5q. You first try the ESAs. If ESS fail, then you use either HMA or lenalidomide. Both options are available. You may choose to use one over the other. There's no way of predicting which patient is going to respond to HMA, which patient is going to respond to lenalidomide. And once these fail, you would go for a transplant. If you have a SF3B1 mutation, or even otherwise, you may decide to use luspatercept. And if it fails, go for a transplant. If it's a hypoplastic MDS, you would use ATG. And if it fails, you would go for a transplant. So that's the algorithm of how today you would manage a low IPSSR MDS. And if you have a high IPSSR MDS, you see if the patient is transplant eligible or not. Supportive care. Then use HMAs if the blast count is high in the bone marrow, along with ion chelation, and then decide to go for an allogenic transplant at the earliest. If the patient is transplant ineligible, use HMAs. If they fail, either clinical trial. If it's an unfit patient, try low-dose chemotherapy or best supportive care. And if he's fit, if he transforms into AML, just reconsider whether he could still undergo a transplant. If he can't, go for some experimental therapy if available. So that's how you would manage a high IPSSR AML. Transplant in MDS is the only curative treatment. It is limited to younger patients. You must select the patient carefully. And the timing of transplant is important, right? So upfront transplant is indicated only for a high IPSSR risk patient, right? So that patient with the autoimmune cytopenia, if he ultimately had turned out to be a low IPSSR MDS, I would still not have transplanted him if he had a donor. I would wait. So you can have a good quality of life for many years with lenalidomide or with hypomethylating agents, and only at progression of the disease must you consider transplant. So just to confuse the matter a little further, this is one of my last slides. I'm just putting two cases, and for the sake of simplicity, both of them have, say, the same features. It's a 40-year-old patient who has pancytopenia and has severe anemia. The bone marrow shows dysplasia. The FISH and karyotyping are normal here. So this patient classifies as a low IPSSR, right? You're not supposed to transplant these by conventional wisdom so far. But then you have NGS available now. So you do NGS, and in the first patient, you see a TEC2 mutation with a WAF of 20%. He has an HLA identical sibling. And the second patient has an ASXL1 mutation and an EZH2 mutation. And both of them have HLA identical siblings. So what are you going to advise the first patient and the second patient? That's the question. So as knowledge evolves, we will know based on the NGS and the mutation profile, you would surely in future have changes in the IPSSR, right? So those who have double mutations. So ASXL1 and EZH2 both are higher risk mutations. They have higher tendency to progress to AML. And particularly if you have more than one mutations on NGS, that is a patient who is much more likely to progress to AML earlier than somebody who has, say, a TEC2, which is said to be a low risk mutation for progression to AML. So you may want to transplant this patient much earlier than the patient on your left. So with that, I would like to conclude by these statements, and I apologize for using rather unscientific language here. So the diagnosis of MDS can be black and white, or it can be gray. And you must complete the cytogenetic and molecular workup in all patients. The treatment decisions for patients with MDS can also be black and white or gray, and therefore tailoring is required for every patient. And you must give sufficient time. Otherwise, you are going to in these gray patients. So otherwise, you're going to have misdiagnosis. So with that, I conclude my lecture, and I thank you all for inviting me here.
Thank you, Samir, for that great talk. Helped with a lot of cases, and you summarized all the modalities of treatment so beautifully. Siddharth has put up the hand. Before he asks question to you, may I ask you one question?
Oh, please, sir.
About this business of myelodysplastic syndrome versus myelodysplastic neoplasm. Which terminology do you prefer?
Well, actually, it is a neoplasm, sir. So ideally, it should be called as a neoplasm. But then, everybody is so used to the word myelodysplastic syndrome that even in the WHO, ultimately, they have just called it as, it is still just called as an MDS, but the true terminology is a neoplasm. So truly speaking, just like, we had myeloproliferative disorders and they've gone into now myeloproliferative neoplasms. MDS is still a neoplasm, but we are so used to MDS, that we cannot change that terminology.
So just to slightly differ, because this contains so many heterogeneous entities, I personally felt that probably our old terminology of syndrome really commits and connotes exactly what is happening. While not all develop malignancy and die, large number of patients succumb to cytopenia. So my personal opinion is that WHO has made an error of calling this neoplasm and not a syndrome. To me, it is an extremely heterogeneous disease. And as you just summarized in your last two cases, entirely different spectrum. And so many large number of patients finally having cytopenia as their critical issue, not developing malignancy at all, and finally dying of cytopenia and infections and bleeding. So anyway, this can go on. So let's come to Siddharth.
Yes, sir. I also feel, and also if we tell a patient that he is having myelodysplastic syndrome instead of neoplasm, that also gives some amount of, when people heard the term neoplasm, they became too much worried. Unnecessary, maybe the patient having only benign cytopenia, and he or she might get too much of worried if they hear the term neoplasm. Anyway, my question to Samir is that actually this is actually a practical case. One of my friend, he is also a doctor. He had attack of COVID in 2020. Thereafter, his WBC count remained low, around 3,000 to 4,000. But hemoglobin platelet was fine. He didn't have any recurrent fever or other symptoms. Very recently, this last 6 months, his hemoglobin is also coming down, and now he is becoming symptomatic because of the anemia. And WBC count around 2,800, 3,000. So around 4 months back, he had undergone one bone marrow examination, assessment biopsy, and FIS, all were normal. And now when the hemoglobin decreased, and then also after checking the vitamin B, and he didn't have any, splenomegaly, no lymph node. Now also he is asymptomatic except for symptoms of anemia. There is on examination no hepatosplenomegaly, no lymphadenopathy, no sternal tenderness, no bleeding, no fever. And only thing is that it is showing that anemia and leukopenia, and there is no abnormal cell in the peripheral smear. Vitamin B12, folate levels are normal. Reticulocyte count is not increased. And repeat bone marrow aspiration, biopsy, cytogenetics, all aspiration shows dilute with erythroid lineage dysplasia only. That also up to 10%. Biopsy was reported as erythroid dysplasia, normocellular marrow, and erythroid dysplasia, but that to 10 to 15%. Other lineage was perfectly normal, myeloid and megakaryocyte. His cytogenetics karyotyping was perfectly normal, and NGS panel is also normal. So I just want to know what to tell him, what is the diagnosis and how to proceed further. This is my question to Samir and all the panelists, including sir.
Yeah, so this is again that one of the gray cases that I just discussed. So the NGS is normal. So here it's possible. There are two possibilities. So by definition, you may want to call this as an ICUS, right? But there could be an element of autoimmunity in this as well, and you may want to give us a small trial of an immunosuppressant drug and see whether the patient actually responds. It's possible, of course, that he has a clonal disease, but you're not able to pick up the clone by the currently available techniques. So that is always possible, and that is what happens in ICUS. So you may want to treat this patient with a certain amount of immunosuppression. You may want to empirically treat this patient with lenalidomide and danazol and see whether the patient works, because you got to do something for him, right? So you may want to treat with these and see whether the patient actually responds. If he responds to any one of these modalities, you would continue that at lower doses for a long-term period. But what to call this patient? It's difficult right now. Either so I would label him as an ICUS possibly.
And his actually erythropoietin level has come 690. So I'm not.
So erythropoietin may not help so much.
I have not actually offered, and so I just I saw your presentation, and you have presented one case who responded very well to prednisolone. So I was tempting, although reticulocyte count is low, whether we can give a trial of prednisolone.
So see, in an autoimmune hemolytic anemia, you can have antibodies which are against the red cell precursors or the reticulocytes or the mature erythrocytes or all of these. And therefore, you may not have, it's not at all necessary to have a reticulocytosis.
That's why I'm tempted whether to give a trial of steroid or not before giving to lenalidomide and.
Yeah, I think it may be justified.
And in your patient, you gave prednisolone.
But I would like to take Dr. Agarwal's opinion.
No. I think you are absolutely fine, but we must proceed now. So, Dr. Shilpa, your question.
Good morning, sir. Good morning, Dr. Sameer, sir. Excellent presentation, sir. It was very, showed your clarity of thought on the topic. My questions, I have two questions. Like your first case was there in which there was isolated leukopenia. Now, if the patient has an isolated thrombocytopenia, now that can be a very big pitfall for us, because whether it is, and the patient may not have a very clinically significant thrombocytopenia, maybe around more than 30,000-40,000, and no bleeding tendencies. So do you recommend doing NGS in all the patients who may be ITP versus refractory thrombocytopenia, as in MDS of unilineal age dysplasia?
Yes. So if the
before doing a marrow, do you recommend NGS, or you, because in marrow we may just get adequacy or non-adequacy of megakaryocytes? Sure.
So I would definitely do a bone marrow when I'm suspecting, if it's a patient who is not, responding to immunosuppression. If I see it's a classical case of ITP where the hemoglobin and platelets are perfect, WBC count is perfectly normal differential, I may first give a trial of immunosuppression. If the trial does not work, then I would do a bone marrow. And if the bone marrow shows any evidence of dysplasia, I would immediately go in for a detailed workup. Even if it does not show dysplasia and I've exhausted all my treatments for ITP and the patient is not responding, there again I would do an NGS. And particularly in younger patients, in children, where you are likely to pick up hereditary causes of thrombocytopenia.
Okay, sir, thank you. My next question is, what would be, do you routinely recommend prophylaxis, antiviral, antibiotic, antifungal prophylaxis in these patients of pancytopenia, MDS? Which all prophylaxis do you prefer?
Well, that would probably depend upon what the degree of cytopenia is and what I feel is the level of immunosuppression that the patient inherently has, or what I'm going to treat him with. And accordingly, I would decide whether the vaccination should be done or not. In a very low risk case, I may not, but in severe cases, I would definitely vaccinate them. Maybe for Prevnar, for hepatitis B, for herpes. So all these vaccines I would definitely give.
Thank you so much, sir. Thank you. Thank
you, Dr. Aditi.
Thank you, sir. So my question is in a patient of 5q deletion MDS. So I have a patient started on 10 mg lenalidomide, 4 weeks now, still transfusion dependent. So what dose of lenalidomide do you start, and do you give it continuously or 21 out of 28 days? And when do you expect a response in such patients?
So in 5q minus, for a patient whose average weight, the recommended dose is 25 milligrams of lenalidomide. And I think at least in this indication, one must attempt to give the full dose of lenalidomide if the patient is tolerating it. And so
we are not
going to be given for 21 days in a month, and only if the patient has not responded.
Samir, intermittently we are not able to hear you.
Oh, I'm sorry, sir. Am I audible now?
Yes, you are.
Yeah, so I said that I would give full dose of lenalidomide, which is with the recommended dose is 25 milligrams for 21 days in a month. And only if the patient has not responded to about 2 to 3 months of lenalidomide would I say that the patient is refractory. Was I audible?
Yeah, you're audible. Fine. So do we move or?
Thank you, sir. Sorry, there was some network issue. And sir, another question is in a patient with hypoplastic MDS who's fit. So would you recommend immunosuppressive therapy or upfront transplant?
So if a patient has he's young and has an HLA identical donor or a donor where I feel comfortable transplanting, maybe an unrelated donor who's 10 on 10 match, I would definitely proceed with the transplant. And
Thank
only
you.
Otherwise would I go for immunosuppression.
Thank you, sir. So that 25 mg of lenalidomide would be 21 days every
Yes,
4 weeks.
Yes.
Okay.
Yes.
Thank you.
Samir, in MDS, you will use 10 mg, no? 25 is for the myeloma.
So actually, for the 5q minus syndrome, the trials that were done were with 25 milligrams only. And it's only later on, where if you have a patient who's got cytopenia, so that typically in the 5q minus, you would have only anemia and in fact thrombocytosis with a normal white cell count. So in these patients, they can tolerate a good dose of lenalidomide. And it's only in the ones who are cytopenic as in the WBC count is also low. That's where you would want to use a much lower dose, say 5 or 10 milligrams.
Sure. Sumit, your question.
Audible, sir?
Yeah, you're audible.
Thank you for your excellent talk, sir. I have 2 questions for you. First is, you covered those patients of MDS who have some amount of autoimmune overlay. So these patients who have some amount of undifferentiated arthritis or a previous history of Sweet syndrome. So what is the long-term outcome of these patients without transplant? Maybe if they are only on steroids, something like that.
So if they have a clonal disease, then they are likely to proceed to progress into AML at some point of time. It may take a decade. If they are alive, it may take, more than that. So nobody knows the risk of progression, but it is small, but eventually, given time, all of them will proceed into AML sooner or later.
If you have a high-risk MDS who had some autoimmune features and he achieved a complete remission with, say, steroids, and he's young and fit, so you would
have to transplant this patient. You have to transplant this patient. So that that girl whom we had with the EZH2 mutation, who had severe autoimmune cytopenia, even if she would have responded to immunosuppression, she's ultimately likely to convert into AML at some point of time. So I would probably then monitor this patient, and at the earliest evidence of progression, I would transplant this patient.
Right. And for these non-5q deletion MDS patients with persistent anemia, whom we give EPO, at times we have to go up on the doses. There is some data that if you had low dose GCSF, there is some response to the erythroid. So if you have a patient whose neutrophil count is normal, but still they're not responding to the maximum dose of EPO, have you added low dose GCSF in these patients, and what is the experience?
No, I have not added in such patients. I generally do it if there is some neutropenia also. So, I'm not sure whether it would really help in that situation, but you can try it. Apparently in SF3B1 mutations, adding GCSF even with the normal WBC count can help.
Okay. Agarwal sir, your take on that?
Yeah, so we do try giving full doses of GCSF to all these patients, and about 5 to 10% of patients benefit after they've received 2 to 3 months of full dose, either erythropoietin or darbepoietin, irrespective of the WBC counts. It's a treatment for the anemia itself. Yeah, I think that's about all. So in practice, one does it because as such, you don't have too many options. Luspatercept, of course, is a recent addition, but for only a small number of patients. So before we call it a day that no ESA, we give GSF to almost all patients who have failed ESA.
Okay.
Yeah, Dr. Arihant.
Sir, good afternoon. So my question is regarding the hypoplastic MDS again, particularly who are NGS positive, and whether their IPSS is in the low risk category or it's more than 3.5 R IPSS. Your take on ATG cyclosporin L-Trombopac combination? And if you do give that, how much time do you wait before, say, switching to a HMA kind of approach if they are like DNMT3 TET2 or ASXL1 positive?
Yeah, so if the mutation is not a really high risk one, and I feel that this patient is actually truly low risk IPSSR, then I would probably give ATG cycle, the triple immunosuppression, and wait. And if the patient has a good response, as I said, we would need to monitor them very carefully, periodically, monitor their blood counts and see whether they are having any, whether they have any evidence of progression. Second cytopenia, once again, monitor them carefully, and as and when required, do a bone marrow. Look at the probably, after a variable period of time, you may want to again do a marrow and again check and see whether they have clonally evolved and a new mutation is also developed. And in that case, you would then decide to take them up for a transplant. You would not take them for a transplant immediately, unless if it's a high PSSR or really bad mutation to begin with.
And sir, where do you fit in the HMAs in the hypoplastic MDS?
In the hypoplastic MDS, I generally tend to avoid, I don't know about sir, but I generally tend to avoid the HMAs because they can cause too much of worsening of the cytopenias. So I would try and, if possible, the ATG. But it's probably depending upon the depth of the cytopenias, I may decide to use low dose of HMAs and see whether they respond. But you've got to do it very carefully because HMAs, as you know, in the first few months can cause cytopenias by themselves. And therefore, you've got to weigh the risk of infections versus the benefit of these HMAs.
Any more questions, Aryan?
That's all.
That's it. Thank you. Dr. Aditya.
Thank you for the excellent talk, sir. So I have two questions for you. So first one is regarding the differential diagnosis of MDS, that the conditions that you mentioned, including infections. And during my training as in clinical hematology as DM in PGI, we came across a patient with tuberculosis who had dysplasia in bone marrow, and with treatment it improved. So I just wanted to ask, in these kind of situations, do you do follow-up marrows once the cytopenias improve, or you just monitor the counts?
Well, I would probably monitor the counts if it was clearly an infection and the counts have completely normalized, and to begin with my workup for the genetic workup for MDS was negative, then I would probably just wait and on a case, that will of course be on a case-to-case basis. If I had a high suspicion, I know there's an underlying MDS and he's got some infection, then I may want to repeat it after a certain number of months, but otherwise no.
Okay. So my second question is regarding the sequencing of marrow and NGS in patients with isolated cytopenia involving a single line. So recently I came across a dermatologist, 35 years old, who incidentally was found to have leukopenia and neutropenia in the range. TLC was 3,000 to 4,000. And ANC was in the range of 100 to 1500, multiple values over last 3.5 years. And then she actually retrieved a report of 5 years ago during the pregnancy that was also showing a similar TLC and ANC. But she was very apprehensive about bone marrow examination. So in situations, although in the recent visit, we deferred the marrow for in the follow-up visit after 3 or 6 months, because she was completely asymptomatic and hemoglobin and platelet counts were normal. So where are the situations where you do NGS before marrow, or do you follow a strict algorithm?
That's a very good question. And I want to tell you and everybody that, if you're suspecting a MDS, do not do the workup or the NGS on the peripheral blood. Okay, because and we've seen this happening actually, where there was a classic patient of who had MDS, he had multiple mutations, but nothing was there on the peripheral blood. And only when we depleted the marrow, on the marrow we found, because these are cells which are, they're trying to get destroyed before they leave the marrow. So hardly this clone is not so much present in the blood. It's all inside the marrow. So you're very likely to get a normal report on the marrow, on the peripheral blood. So always do a marrow in these patients. Okay, and whether you want to do this also in these patients. So personally, if you ask me, in our institution, since we have a chromosomal microarray, I do this as a very good screening test for the entire for all these mutations. So if I see a copy-neutral loss of heterozygosity in a particular suggestive gene, or we actually find some deletions, then I would sort of kind of label it as possible MDS and then do a myeloid mutation panel.
Fine. Thank you, sir.
Thank you, Aditya. Dr. Alka.
Hello, Dr. Sameer. Thank you so much for, explaining this most challenging, and I would rather say gray hematological disorder in a very beautiful, lucid manner using your real life cases. So thank you again for that. So I will be just asking a few very simple questions, practical questions. So when we are using hypomethylating agents for high-risk patients, or maybe intermediate risk patients, during that period for initial 2-3 months, we will be having cytopenias. So do you use ESA, GCSF, or TPO agonists along with HMAs or not?
I use it all the time.
Because sometimes it is mentioned that in this high-risk categories, they are having excessive blast. They might, progress to AML faster, kind of this. So use of these growth factors sometimes kind of dubious. They have dubious.
Yeah, but they might die of infection if you don't use them, and therefore that's probably the lesser of the evils to use them rather than not. So in a given situation, I would prefer to use them, I would say.
Okay, thank you. The next question is any role of oral azacitidine use?
Yeah, so I actually use it quite frequently, especially in the the elderly fellow. Yeah, in MDS. So an elderly patient who doesn't want to come to the hospital, doesn't want to take an injection, he's frail, he wants to sit at home and manage. I just use oral azacitidine, and it works. I can tell you it works. I've had a lot of instances where it helps.
Okay, and what about chelation therapy?
Yeah, so chelation therapy forms an important part of the treatment, especially in those who have ring sideroblasts, SF3B1 mutations. So those who are sufficiently, transfused and their ferritin levels cross 1,000. In these patients, one would and you expect that the patient is not going to go in for an immediate transplant, or his survival is going to be really long term. Only in these patients would you want to use chelation therapy. If you know that it's a high risk MDS and within 6 months to a year he's going to progress to AML, then it doesn't make sense.
And one last question. So when we are putting these patients on hypomethylating agents and all, we know they are immunosuppressed. Do you give any kind of immunization before putting them on these therapies?
Yeah, so this question was asked actually, and I kind of answered it a little earlier. And yes, so in those patients who I feel are sufficiently immunosuppressed, I would use prophylaxis. So pneumococcal, herpes, hepatitis, all these immunizations I would use.
Okay, thank you so much. Thank you so much.
Thank you, Dr. Alka. We take a few questions from the audience now. So there's a question: pediatric patients with unexplained cytopenia, will you evaluate for IBMFS before you label them as MDS?
100%. 100% I would.
Should NGS IBMFS panel be sent in addition to the NGS?
So that depends upon what you suspect. You can ask for a clinical exome sequencing directly, and then that would cover the most of your of all these mutations. So depending upon what you feel the clinical profile is, you may decide to ask for the panel, and you can also speak to the molecular lab that is doing the workup and discuss with them and decide to cover all the relevant genes.
What is the difference in the sensitivity of NGS done from bone marrow versus peripheral blood?
As I said, if you're suspecting MDS or any such cytopenia, you must do it on the bone marrow, not on the peripheral blood.
Samir, here I will slightly differ. Probably the sensitivity of peripheral blood is almost as good as bone marrow. So if the patient is not enthusiastic about doing bone marrow and with a very elderly people, and as such not going to be transplant fit, and you have a question of diagnostic problem, then very often NGS from peripheral blood can help you in a large number of patients.
Okay, so I only said this because there was a patient who had about 3-4 mutations. He was a therapy-related MDS, and on his peripheral blood, all the mutations came out negative. And when we repeated the test, because it was positive in a marrow done outside, so when we did the repeated test on the marrow, there was a significant number of mutations that we picked up in the bone marrow, including TP53. And so that I came to the conclusion that some of these cells may not enter the peripheral blood itself. They could be so the clone would not enter the blood so much, and therefore the sensitivity of a marrow would be far superior. But if in your experience or in literature, if it is said that this can be picked up on the blood, it's possible. So yes, of course, I mean, like a chip, of course, would be picked up on the blood at a low VAP, so you could pick up these patients. But marrow would be by far a better test than the blood.
Dr. Arihant has raised his hand. Arihant, your question?
So, sir, my question is regarding the dose of TPO-RA in markedly thrombocytopenic MDS patients, like one when you are using them as a single agent, or when you are using them in combination with HMA, like say for L-Thrombopag, where do you start with, and what is the maximum you go, if at all?
So in literature, L-Thrombopag, 150 to people have even used 200 milligrams, but about 150 milligrams is what I would give these patients. So low dose may also work, but if you want to really give a full dose, it would be maybe 150 milligrams. And romiplastin would be about 20 micrograms per kg. That's between 10 to 20 micrograms per kg. That's what would be the starting dose, and then you may decide to combine.
And this is irrespective of the cellularity. Yeah.
So there's no. So I don't think there's any prescribed dose or any official. It's actually not licensed even. But so you can decide what the dose should be. You can start off with the lower dose if you want, and then escalate the dose, or do the reverse. Start with the higher dose, and then if there's a good response, lower the dose.
Okay.
Thank you. There are questions about upfront transplant versus giving couple of cycles of HMA and then doing transplant. And there have been varied questions on various situations. I will not bother about situations. What's your take? Will you prefer to take a couple of cycles and then do transplant, or do you direct transplant as well?
So if you these hypomethylating agents would be used in these patients only if there is a sizable proportion of blasts in the marrow or the peripheral blood. So if the blasts are in excess of 10%, I might prefer to use an HMA, and otherwise I would just proceed with transplant directly.
And other question is, how many cycles of HMA you must give before calling patient as non-responsive?
That again is not very clear, but generally about 4 cycles at least must be given, 4 to 6 cycles of HMA before you call it a day.
Right. MDS, deletion 5q, low risk, patient presenting only with anemia, responded well to lenalidomide but lost the response after 2 years. And there was no response to EPO, no response to HMA. Patient still has only anemia. Should you go for transplant?
This patient would ultimately require a transplant because the patient is not going to respond otherwise, and he's going to progress much later to AML, but the cytopenias would be, the transfusion dependence would be quite significant very soon.
Thank you. The questions about doing copper and zinc levels in patients of suspected MDS.
Those patients who are probably on Ayurvedic medicines or, have occupations where this would be, suspected, you must look for these. We would want to do these tests.
And just one addition there, Dr. Nishad, copper deficiency leads to ring sideroblastic changes and vacuolated erythroid precursors. So if your marrow has shown ring sideroblast and vacuolated macronormoblast or megaloblast, then you should search for the copper deficiency.
I'm not aware, sir.
Yeah, there's occasional rare condition. Savitri Singh wants to know, at times cytopenia with dyspoiesis yet may not have cut off more than 10% of lineage cells. All other causes ruled out. Will you follow up with the molecular testing and cytogenetics so that you have a diagnosis? So less than 10% of dysplasia and cytopenia. Will you do karyotyping and NGS?
I would, sir. If there is a suspected, if there's a cytopenia in the peripheral blood and this is the situation, yes, definitely I would. Even if there's not much of dysplasia, you can very well have mutations suggestive of MDS, and that would in fact stamp the diagnosis of MDS if you pick up any of these mutations. So yes.
Next question is about, do you use IPSS-M in your routine clinical practice to stratify your patient to decide whether to transplant or not? And has it replaced IPSS-R in your routine day-to-day practice?
Well, it has not very clearly, but I'm not very sure whether of the correct answer. So I would probably use the IPSS-R right now. Look at the the molecular profile, and then probably on the case-to-case basis decide how to proceed.
Another question is about role of luspatercept without SF3B1.
You can use it in non-SF3B1 mutated patients also, and in certain number of patients you can have a response. So it can be used very well in non-SF3B1 mutated patients also who are low IPSS-R.
So BMS has just completed their study on non-SF3B1 and presented that data both in EHA and ASH, and they have now applied for the licensing to the authorities. And this license is likely to get through because there is significant response, almost about 30% of patients. Once that happens, they will be able to help you. I mean, there is no PAP for luspatercept at all, but if at all they give any PAP, they will be able to give you PAP for non-SF3B1 mutation because that licensing is going to get through within 3-4 months. Yeah, I think that finishes all the questions in the chat box. Shilpa, you have a question.
Yes, sir. Just I would like to know the thoughts on venetoclax usage in which subset of patients, and I mean, I think that's needed in the discussion part of it. Thank you.
Samir?
So maybe in patients who have, a significantly high blast count, where I would suspect them as, an IB2 kind of a situation, there one may attempt using venetoclax as well, very carefully.
Okay. Thank you.
One more question has come up. Is how should we manage a patient of MDS having myelofibrosis? And patient has anemia with thrombocytopenia and HMA 6 cycles have failed.
They should be transplanted?
Transplanted, yes. One more question. Long question. 36 years old male, symptomatic, marked cytopenia, hypercellular marrow but no dysplasia. Karyotyping, negative. Fish, negative. There is a small PNH clone. Has a HLA matched identical sibling. He is ICUS by definition, and we are planning transplant for him. Will you like to do NGS?
Well, NGS, of course, I would want to do. I would definitely want to do it, yes. To know what kind of a mutation he has, so you can predict whether this patient is going to, progress to AML, how soon he would. If you have 2 mutations, you may know that the ATG is only going to improve the cytopenia, but he is likely to proceed to MDS at some point of time. And therefore, such a patient, you would want to probably transplant.
Thank you. That's the last question in the chat box. Any more questions here? I just want to add to one of the questions that was asked about oral azacitidine in low-risk MDS. So there is a publication from MD Anderson, and you know that oral azacitidine did not get approval for low-risk MDS, and they divided their patients into 2 groups. One is only anemia, and one was anemia with neutropenia. And if you remove the patients who had neutropenia, then the patients had excellent response without any risk of infection. While that group of patients who had anemia with neutropenia, when oral azacitidine was used, there was significant increase in the incidence of death by sepsis. And that's why the FDA refused to give the licensing. So if you want to use oral azacitidine for patients of low risk MDS, you should avoid patients who have got neutropenia. Then probably you're doing a good job. Yeah,
Thanks, sir, for this input. Thank you so much.
Alka, you had asked that question. Okay. Yeah, anything more? Otherwise, be difficult. The subject is how controversial the issues are. Samir did a wonderful job of presenting cases and summarizing up-to-date treatment of the entity, and the guys over here, our faculty, as well as those in the chat box, have put up lovely questions and discussion. I would just like to close this webinar by telling one thing, that be aggressive with investigations. And I think Samir was very clear on that front. When you ask questions, whether you should do this, whether you should do that, there is a kind of mind block which is being shown. I always believe that investigations are cheaper, especially if you are going to offer a wrong treatment. Because wrong treatment is the most expensive treatment. It gives you no results, patients deteriorate, and then you have a patient in the advanced stage of disease with poor outcome. So as neurologist does not hesitate in doing imaging, and a cardiologist does not hesitate in doing angiographies, we should not hesitate in doing karyotyping, fish studies, NGS panel, bone marrows, bone marrow biopsies. It's the basic today. I mean, the diagnosis is required to offer the best possible treatment. And today, as I say, MDS is a syndrome. It contains 20, 30 conditions, and the treatment is getting individualized. And as Samir brought that beautifully out, from simple support therapy right up to transplant, you will do injustice to the patient if you have not exactly brought out his prognosis. And that prognosis can only come with, as was asked by somebody, whether you have moved to IPSS-M. Today or tomorrow, you have to move, because that gives you better discriminatory power, so that you can give a serious treatment like transplant versus a conservative treatment. So with that, Samir, thank you very much for opening the Pandora's box. You saw how difficult the situation is and how questions were put up to you. And you did a great job on this Sunday afternoon. Thank you so much. And
Thank you, sir.
again, thank our supporters, NATCO this time, who have sponsored this program. And bye-bye to everybody. Have a great day with your family. Bye. And thanks, Dr. Anand, for being with us. Bye. Bye-bye.